Somnath from INTAS. So we have a topic for management of marginal zone lymphomas for today's MLA session. So let me welcome our eminent guest for today, Dr. Amit sir. Dr. Amit Kurana sir is a highly skilled and experienced hemato-oncologist with a decade of experience in this field. Sir has a fellowship in bone marrow transplant, hematology, clinical hematology, and is an expert in managing hematological and hemato-oncological patients. Sir has experience in performing bone marrow aspiration, bone marrow biopsy, and other hematological procedures. Sir has extensive experience in both autologous and allogeneic stem cell transplant. So we welcome our moderator, Dr. Amit Kurana, sir, for today's session. Dr. Amit, sir, please, sir.
Thank you, Mr. Somnath. Let me share the screen.
Yes, sir.
Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Michael Murley from Milan, Italy, and he's going to lecture us on management of marginal zone lymphomas. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Mr. Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Michael Murley from Milan, Italy. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 2nd of March 2025, from 11:30 a.m. Indian Standard Time and 7 a.m. Spanish time, we have again Dr. Joseph Maria Ribera from Barcelona, Spain, speaking to us on acute lymphoblastic leukemia and update on management. Let me introduce our discussants for the day, and they're displayed here in alphabetical order. To start with, we have Dr. Aditi Jain from New Delhi, Dr. Akanksha Garg from Ahmedabad, Dr. Dheeraj from Chennai, Dr. Indur Ambulkar from Mumbai, Dr. Juvita Martin Daniel from Chennai, Dr. Khushbu Jain from Ahmedabad, Dr. Meher Lakshmi Konatam from Hyderabad, Dr. Monica Chennareddy from Bangalore, Dr. Nidhi Dixit from Kolkata, Dr. Priyanka Srivastava from Gandhinagar, Dr. Rajan Yadav from Ahmedabad, Dr. Roshni Pandey from Jabalpur, Dr. Shyam Agrawal from Bhopal, Dr. Saurav Kumar Mishra from Bhubaneswar, Dr. Sri Gopal Mohanty from Cuttack, and Dr. Tejaswini Gudibande from Bangalore. Now it's time to introduce our guest speaker for the day. You are again with us, Dr. Michael Murley from Milan, Italy. Dr. Michael Murley is Clinical Assistant, Head, Indolent Lymphomas Unit, Division of Hematology, the Fondazione IRCCS CA Granda, Ospedale Maggiore Policlinico, Milan, Italy. His university educations include: he graduated in medicine and surgery from the University of Pavia, Italy in the year 2005. He then received his postgraduate diploma in hematology from the University of Pavia, Italy in 2009. His clinical activities include: he is a clinical assistant at the Division of Hematology of the Fondazione IRCCS Policlinico San Matteo in Pavia, Italy from the year 2009 to 2010. He is also the clinical assistant at the Division of Hematology at University Hospital, Ospedale di Circolo e Fondazione Macchi in Varese, Italy. He served as head of the outpatient oncohematology service from the year 2011 to 2023. He was then appointed as Vice Director, Division of Hematology since October 2019. Since October 2022 till date, he held the position of Clinical Assistant at the Division of Hematology of the Fondazione IRCCS CA Granda Ospedale Maggiore Policlinico in Milan, Italy, as head of the Indolent Lymphomas Unit. His main areas of scientific activity include the diagnostic, prognostic, and therapeutic aspects of non-Hodgkin's lymphoma. In particular, he also participated in the development and validation of new prognostic models in NHL, such as FLIPI-2 in follicular lymphomas, hepatitis C prognostic score in HCV-positive diffuse large B-cell lymphomas, as well as POD24 in marginal zone lymphomas and MZL-IPI scores. He also coordinated many studies on the relationship between chronic hepatitis C virus infection and indolent lymphomas and DLBCL, with a special focus on the impact of the new direct-acting anti-HCV antivirals drugs in the patients with HCV-positive DLBCL. In 2022, he also published on behalf of Fondazione Italiana Linfomi the results of the first prospective study on the use of direct acting anti-HCV antivirals as first-line curative therapy in patients with HCV-positive indolent lymphomas. He also participated in pivotal phase 2 and phase 3 clinical trials of new targeted chemo-free drugs for the personalized treatment of B-cell lymphoid neoplasm, such as PI3 kinase inhibitors, that is duvelisib, BTK inhibitors like ibrutinib, cenobrutinib, and pirtobrutinib, as well as anti-CD20, anti-CD3 bispecific antibodies, namely odronextamab, epcoritamab, and mosunetuzumab. Finally, he is the coordinating principal investigator in a prospective nationwide study of the FIL, evaluating prospectively the activity and the persistence of COVID-19, VZV, and childhood vaccines in patients with follicular lymphoma undergoing immunochemotherapy and anti-CD20 maintenance. He also coordinated a multidisciplinary group of hematologists, immunologists, and infectious disease specialists on behalf of FIL long survivors, comorbidities, and quality of life committee in a project evaluating the activity of vaccines in patients with lymphoma, which has been published in the British Journal of Hematology. His participation in research groups include: he's a founding member of the Fondazione Italiana Linfomi and is a member of the board of the Indolent Lymphoma Committee. In 2024, he was appointed representative of the FIL in the International Extranodal Lymphoma Research Group. He is the author of about 100 research articles in index journals, including the Journal of Clinical Oncology, Blood, Hematologica, Annals of Oncology, Blood Advances, Clinical Cancer Research, American Journal of Hematology, The Oncologist, as well as the British Journal of Hematology. And today he's with us and he's going to lecture us on management of marginal zone lymphomas. Well, thank you so much. I stop over here. Over to you, sir.
Thank you, Dr. Kurana, for your very kind introduction. I'll share my presentation. In the meanwhile, I would thank you and all the organizer for inviting me to speak about this, for me, very interesting lymphoma. This is my favorite lymphoma, to a very large audience like your group. So if you see my presentations, okay, I can go forward. These are my disclosures. Just a moment. Okay. Marginal zone lymphomas are a heterogeneous subgroup of indolent lymphomas. There are about 70% of all non-Hodgkin lymphomas, and there are three distinct entities, namely extranodal marginal zone lymphomas, the so-called multilymphomas, nodal marginal zone lymphomas, accounting about 10% of cases, and splenic marginal zone lymphomas, accounting about 20% of all marginal zone lymphoma cases. In the last two classifications, namely WHO 5th edition and International Consensus Conference, the primary cutaneous marginal zone lymphomas were listed as a separated entity. So this is the overview of my presentation. I will talk you about diagnosis and molecular pathogenesis, about epidemiology, clinical presentation, prognostication, initial assessment and response criteria, treatment, and finally conclusion and perspectives. Let's start about diagnosis and molecular pathogenesis. This table summarizes the main differences between the first edition of WHO classification and fifth edition and ICC 2022. As I mentioned before, the primary cutaneous marginal zone lymphoma are listed as a separate entity in WHO 5th edition, and as well disorder that means that it's very indolent in the ICC 2022. There are almost no differences in nodal and splenic marginal zone lymphoma classifications criteria. However, there is a new entity in WHO, including encompassing the HCL variant and some cases of B-cell prolymphocytic leukemia that is named splenic B-cell lymphoma leukemia with prominent nucleoli. I will talk about only marginal zone lymphomas in these lectures. These are the main histological characteristics of mild lymphomas. Mild lymphomas are in mild lymphomas, there are always centrocyte-like cells with lymphoepithelial lesions. There's frequently plasma cell differentiation with scattered transformed cells with admixed reactive T cells, and frequently we can find follicular colonization. This cartoon summarizes the main aspect of pathogenesis of mild lymphomas. Many infectious agents are linked to some specific sites of mild lymphomas. I will talk you in the next few minutes. There are also other autoantigens linked to autoimmune manifestations such as Hashimoto thyroiditis in thyroid mild lymphomas, myoepithelial sialadenitis with Sjogren's syndromes in salivary glands, mild lymphomas, and rarely there is lymphoid interstitial pneumonopathy in lung mild lymphomas. As represented in the cartoons, there are some typical translocation in specific sites, frequently in gastric marginal zone lymphomas, the translocation between 11 and 18 chromosome, API2 MALT1 translocation of 1418 EGHV MALT1, and rarely translocation 114 for each EGHV BCL10. All these translocation lead to deregulation of NFA-KB signaling. That is the hallmark of marginal zone lymphoma molecular pathogenesis. This cartoon summarizes the model of tumor progression of gastric marginal zone lymphomas. There is, as all you knows, there is the Helicobacter pylori infection leading to a multi-step process of gastric inflammation with a first phase of BCR-dependent autoimmune inflammation with NFA-KB activation, and then after the acquirement of some genetic events such as the cited translocation EGH MALT1, BCL10 IGH, or BIR3 MALT1, the process progressively become BCR independent with increasing NFKB activation, and this phase may be not responsive to antibiotic eradication of Helicobacter pylori. These are the characteristics of splenic marginal zone lymphomas. That is an indolent non-Hodgkin lymphoma involving spleen, bone marrow, and frequently peripheral blood. The diagnosis is frequently occasional due to lymphocytosis. In other cases, there is a symptomatic splenomegaly with cytopenias and autoimmune manifestation. The definitive diagnosis relies on spleen histology by splenectomy. However, if not available, that is the usual today case, the diagnosis requires an integration of bone marrow histology with morphology, immunophenotype of bone marrow or peripheral blood, and clinical data. However, in some cases, the diagnosis may be challenging. There is not a pathognomonic immunophenotypes. However, the immunophenotype is the one typical of B-cell lymphoma, CD19, CD20, CD22. CD23 is usually negative, CD5 is usually negative, but there are also cases CD5 positive, CD10 negative. So the Matute score is usually 0 to 2, and obviously in immunohistochemistry, cyclin D1 is negative. In spleen histology, there is a marginal zone expansion in white pulp, and in bone marrow biopsy, there is a typical pattern of infiltration that is the synodal pattern that is usually associated with other pattern infiltration, namely the nodular pattern. So the question is splenectomy necessary of splenic marginal zone lymphoma diagnosis? The response is no, because we have an integration of cytology with demonstration of villus lymphocytes, a flow cytometry that is compatible to the one that we listed before. So this is the full immunophenotype with Matute score less than 3. And the bone marrow histology with intrasinusoidal infiltration, you can see the infiltration of the sinusoidal in the bone marrow showed by CD20 staining. We can do the diagnosis of splenic marginal zone lymphomas without splenectomy. What about molecular pathogenesis? This cartoon summarizes the main genetic hallmarks of splenic marginal zone lymphomas. There is frequently a NOX signaling mutation in about 40% of cases. Also, always NFKB signaling mutations, TRAF3, TRAF2, BR3. And also there is a mutation of KALF2 in about 20 to 40% of cases. Frequently, there is a chromosomal abnormalities that is a 7q deletion in 30% of cases. And also there is we can found a biased EGHV usage in about 30% of cases with usage of variant genes 1204 cluster. So this is the genomic profiling for differential diagnosis in indolent lymphomas. You can see KALF2 mutation are typical of splenic and nodal, notch mutation of these two subtypes. Frequently there is also a trisomy of 3, trisomy of 18 chromosome in all these 3 subtypes, and del-Q, that's deletion of 7q in splenic marginal zone lymphoma. There are translocations that are typical of some sites of mild lymphomas, and we have to exclude the genetic hallmarks of other indolent lymphomas entities, such as, for instance, cyclin D1 in mantle cell lymphoma that's frequently a leukemic phase. The typical translocation of 1418 BCL2 in follicular lymphomas, MYD88 in lymphoplasmacytic lymphoma, and BRAF mutation in HCL. As I mentioned before, there are site-specific molecular hallmarks in extranodal marginal zone lymphoma of SMALT, and this is what is listed in new WHO classification. In this cartoon are also listed some etiologies agents that such as Helicobacter pylori in gastric marginal zone lymphomas that are linked to specific mutation or translocation. So marginal zone lymphoma may mimic other diseases, and some genetics exams or molecular mutation may allow to do a clear differential diagnosis. However, there are some areas of overlapping. I mentioned an important study that has been published in Blood in 2022, that is the IESG 46 studies that enroll more than 300 patients with a collection of fresh spleen samples. So splenic marginal zone lymphoma were confirmed by pathologic revision, and all the cases came from splenectomy. And in all these cases, the authors in Bellinzona, Switzerland, performed a very large set of molecular tests, such as targeted NGS, mutation, gene expression profiling, immunoglobulin sequencing, and we collected also clinical data. And these are the mutation that has been, found. So the most frequent mutation in splenic marginal zone lymphoma is KLF2 in 20%, followed by Notch2, and the others. TP53 is typically mutated in about 11% of cases, and in a few percent of cases there is also a mutation of MYD88. These are the pathways that are disrupted in splenic marginal zone lymphoma. So epigenetic pathway in about 40% of cases, Notch pathway in 42% of cases, and NFAKB in 36% of cases. So the authors found four different genetic subtypes, but the most important are the so-called DMT, that means DNA damage response, MAP kinase, and toll-like receptors, which is enriched in mutation of TP53, ATM, BRAF, and MYD88, and a larger subgroup that has been called NNK, that means NFKB, Notch2, and KALF2, which is enriched in this mutation in these pathways. And there are two other smaller subgroups, PA for PI3K AKT, and CBS, cytokine BCR and splicosome group. And these four groups divide in two other subgroups that are two subgroup evaluating the milieu that is maybe immunosuppressive or immune silent. And you can see that this classification has also a prognostic value. However, it's not still in clinical practice, but probably in the future, with availability of genetic and molecular tests, it will become more widely used. So we can see that then T3-year overall survival in this series was 68.5%. The 10 years relative survival was 82%, so less than 18% with respect to the matched general population. The relative survival was 85% in DMT and 79% in NNK subgroup. The immune silent subgroup has not different relative survival, while the immune suppressive subgroup in the macroenvironment, so if the macroenvironment is immune silent, there is no difference. If the macroenvironment is immune suppressive, there is a worst survival. And combining these two subgroups, genetic and macroenvironment, you can see that the combination of NNK and immunosuppressive macroenvironment has the lower survival at 10 years, 70% compared to 82%. So let's speak briefly about the third subtype, that is nodal marginal zone lymphoma. Sorry. Okay. It is also called monocytoid B-cell lymphoma. The median age is 64 years. Usually there are no symptoms and there is a good prognostic status. Typically, there are disseminated lymph nodes, non-bulky, with bone marrow involvement in about 30% of cases. The diagnosis require the exclusion of splenic marginal zone lymphoma, so no splenomegaly, and the exclusion of MALT, marginal zone lymphoma, so no extranodal involvement. There is a distinct molecular pathogenesis that is illustrated in the cartoon. There are many overlapping with splenic marginal zone lymphoma. However, the mutation of PTPRD is typical of nodal marginal zone lymphoma and is found in about 20% of cases. The treatment criteria are the same of follicular lymphomas, and the treatment is usually immunochemotherapy, such as in follicular lymphomas. Few information about epidemiology. These are US data from SIR registry. In 2016, about 7,040 cases, 400 cases were diagnosed with marginal zone lymphoma, and about counting about 7% of all mature non-Hodgkin lymphomas. Based on SEER program, the standardized incidence rate for marginal zone lymphoma was 1.96 per 100,000 person years. In the last years has been found an increased incidence in about 1% per year, probably due to an improved diagnosis. These are data from Europe. In UK data, marginal zone lymphoma is the third most common B non-Hodgkin lymphoma subtypes, and the 10-year prevalence is only slightly inferior than follicular lymphomas. What about clinical presentation? Obviously, the presentation of extranodal marginal zone lymphoma depend from site-specific localization, so their symptoms are site-specific. Nodal marginal zone lymphoma, as mentioned before, require exclusion of splenic and MALT marginal zone lymphoma. Typically, there are disseminated lymph nodes. Splenic marginal zone lymphoma median age is at about 67 years. And the picture, the clinical picture has been previously described. Typically, there are splenic hilar lymph nodes in about 25% of cases. And frequently there are autoimmune manifestations, such as autoimmune hemolytic anemia, thrombocytopenia, and neutropenia. However, for clinician, marginal zone lymphoma frequently are a continuum of related entities. Frequently, splenic marginal zone lymphoma cases have also skin involvement, but also peripheral blood and nodal involvement. So, and frequently there is a leukemic picture. So probably there is a continuum of related clinical entities. There is also a sort of monoclonal B-cell lymphocytosis without splenomegaly, without lymph node involvement, without cytopenia, that is called monoclonal B-cell lymphocytosis marginal zone-like. It is a non-CLL monoclonal B-cell lymphocytosis. What about outcome prediction, so prognostication? As you can see, the survival, the overall survival of gastric marginal zone lymphoma is not different from a matched general population, while survival of non-gastric extranodal marginal zone lymphomas and splenic marginal zone lymphomas is significantly inferior than matched general population. And it is not depicted here, but the prognosis of nodal marginal zone lymphoma is worse of other subtypes. This is the prospective Fondazione Italiana Lymphoma Studies, the so-called NF10 study. This is the overall survival of the three distinct entities. We've also disseminated operational subtypes. This is an operational group, and as you can see, the survival of nodal marginal zone lymphoma and disseminated marginal zone lymphoma is the worst at 5 years, while the prognosis of extranodal marginal zone lymphoma is the best at a long-term interval. What about prognostic score? There are a plethora of prognostic scores in marginal zone lymphoma. There are subtype-specific prognostic scores. For instance, for splenic marginal zone lymphoma, there is the II score from Intergroup Italiana Linfomi, that is an old Italy group, and the HPLL score from the European and Spanish, coordinated by Spanish group, that is also been modified and updated. There is no specific prognostic index for nodal marginal zone lymphoma. We usually use FLIPI as for follicular lymphoma, while there are a large number of prognostic indices in extranodal marginal zone lymphoma. The most frequently used is MALT, IPI, and then there are some modification of MALT, IPI. In this slide, all these prognostic scores are described with acronyms and risk groups and survival. I'll mention and describe MALT IPI, that is the most frequently used. The three variables are very simple: age more than 70 years, elevated LDH, and Ann Arbor stage 3 or 4. So you can see that there are three different survival curves for event-free survival, progression-free survival, overall survival probability, and cause-specific survival. Another important aspect in marginal zone lymphoma that has been demonstrated for the first time by our Italian study, NF10, is the prognostic importance of progression of disease within 24 months. So if there is a progression event within 24 months from diagnosis, the probability of overall survival is is worse, and this has been demonstrated in all marginal zone cases, but also in subgroups of splenic marginal zone lymphomas, disseminated marginal zone lymphoma, and extranodal marginal zone lymphomas. And this figure has been confirmed in other series from US and from Europe. However, obviously, this is a time-dependent prognostic events. We can use this prognosticator at diagnosis. In Italian group, we tried to develop a unified prognostic score model for all marginal zonal subtypes. So extranodal, splenic, nodal, and disseminated form. This new score would be very useful for stratification of clinical trials, as usually today clinical trials enroll all subtypes of marginal zone lymphoma, especially for testing new agents. So a unified prognosis score will be very useful. These are the definitions. As you can see, disseminated marginal zone lymphoma allow the presence of all sites of involvement, so extranodal, spleen, lymph node, bone marrow, and peripheral blood. These are the variables associated with prognosis, progression-free survival in univariable model, and in the multivariable model emerged 5 parameters, namely LDH, absolute lymphocyte count less than 1 per 10 at 9 liter, hemoglobin less than 12 grams per deciliter, platelets less than 100, and the subtype splenic and extranodal that are the reference, while nodal and disseminated marginal zone lymphoma are associated with worse prognosis. So combining these 5 variables, we developed a prognostic index with different progression-free survival. So 0 factor, the low risk group, was associated with 80%, 85% of 5-year progression-free survival. 1 or 2 factors were associated with 66% of 5-year PFS, but while the presence of 3, 4, or 5 parameters was associated with 37% progression-free survival. This model has been internally validated and also externally validated with 3 series from US, Mayo Clinic, Miami, and another American series. And the prognosis has been confirmed for progression-free survival, but also for overall survival. The model also demonstrated to predict also POD24. So only 6% of low-risk group developed POD24, 15% in the intermediate risk group, and a third in high-risk group. So we propose that this model that has been published in eClinical Medicine last year may be adopted as a unified prognostic model. It is very simple and has been demonstrated and validated in series from different parts of the world, from Europe and US, and may be useful to stratify prognosis and diagnosis in all marginal zone lymphoma subtypes. What about initial assessment and response criteria? These are the tests and the exams that are suggested for all marginal zone lymphoma subgroup. This is taken by our review in educational ASH book 2022. Obviously, familial individual history, physical examination. For the lab, complete blood and differentiation count, LDH, beta-2 microglobulin, renal liver function, electrophoresis, and so on. Very important that viral serologists, we'll speak about HCV. Also, autoimmune tests such as direct Coombs test is suggested, and bone marrow biopsy in splenic and nodal marginal zone lymphomas. This is also recommended in extranodal marginal zone lymphoma, non-gastric, if cytopenias are present, and only local treatment is planned. A CT scan is the mainstay of diagnosis, MRI in specific situation, and PET-CT when local treatment is planned to end in cases which are at risk of histologic transformation to identify biopsy site for biopsy. These are the peculiarity. Marginal lymphoma staging in nodal and splenic marginal zone lymphoma are suggested bone marrow and peripheral blood flow cytometry. In stomach, extranodal marginal zone lymphoma, obviously, and esophagogastrocolonoscopy with endoscopic ultrasonography, that is however, optional. And this stress the importance of Helicobacter pylori status by immunohistochemistry. And if immunohistochemistry is negative, the evaluation of fecal antigen or breath tests and serology studies. The evaluation of translocation 1118 is optional. Small intestine marginal zone lymphoma may be useful to test Campylobacter jejuni status. In the colon, obviously colonoscopy. In salivary glands, anti-SSA Rho and anti-SSA-B antibodies are useful. And typically in ocular adnexal lymphomas, there is an association in certain specific geographic region with Chlamydophila psittaci that has been not confirmed all over the world. So only if there is a high prevalence of this infection, it is suggested to evaluate a PCR in tumor biopsy or in conjunctal swab. So this is optional. And there are other peculiarities depending from the sites. For instance, MRI or CT scan is suggested for the breath, and for the skin, Borrelia-Burgdorferi status is in the tumor biopsy is optional. Lugano classification is not adapted to well evaluate the response in marginal zone lymphoma, and there are some ambiguity in marginal zone lymphoma staging due to different imaging tools, endoscopy, ultrasound, bone marrow evaluation, and so on. And there are specific response criteria for gastric extranodal marginal zone lymphoma, the GILAR criteria, and splenic marginal zone lymphoma, the Matutes criteria of 2008 that are elusive for other extranodal marginal zone lymphoma. The role of PET scan. PET has not been recommended by Lugano classification, but this probably will be modified in the next Lugano meeting and consensus criteria that will be released. The role could be reconsidered because frequently the PET may upstage marginal zone lymphoma and may allow the biopsy of the site with high SUV that is recommended if a histological transformation is suspected. This is more PET is more informative in BALT, so the bronchus marginal zone lymphoma, and there are other sites with physiological activity of FDG, so in some cases may be not very informative. However, PET is recommended if local therapy is planned and the prognostic value of PET diagnosis is debated. Some recent studies showed that bone marrow biopsy may not be required in stage 1 extranodal marginal zone lymphoma treated with radiotherapy. So the need of performing bone marrow biopsy is questioned in very localized cases. So what about treatment? The treatment criteria are not clearly established. In splenic marginal zone lymphoma, there are the Matutes criteria, so if also the ESMO criteria, so if the lymphoma is symptomatic with splenomegaly symptomatic, if there are cytopenias such as anemia, thrombocytopenia, or hyperlymphocytosis, the treatment is recommended. There is an uncertainty in if the nodal disease or elevated DH or B symptoms are treatment criteria. For nodal marginal zone lymphoma are used Guelph criteria, while for extranodal marginal zone lymphoma, there are the disease need to be symptomatic with lymphoma-related disease that may be site-specific. However, if the disease is disseminated, if there is high tumor burden or Barkley disease or organ damage, or if the local treatment is contraindicated or has failed, or anti-infective therapy is failed, there is a need for systemic treatment, also if there is a rapidly progressive disease. Patient with advanced stage but asymptomatic disease should be actively observed with a watch and wait strategy. I mentioned before some infectious agents that are linked to specific subtype of marginal zone lymphoma. This is a model of infectious agent the lymphomagenesis in marginal zone lymphomas. I listed Helicobacter, hepatitis C virus, Chlamydophila psitta, Seborrhea burgdorferi. If the disease is stable, there is no urgency of conventional treatment, the first-line treatment is recommended as a specific anti-infectious treatment that target infectious agent eradication. The eradication of infectious agents may lead to variable rates of lymphoma response, PR or CR, especially in the early phases when the disease is antigen dependent. I mentioned these are a table suggesting the anti-infectious regimen for specific marginal zone lymphoma, typically antibiotic eradication, that is a prevalence of more than 90%, is consistent of PPI, clarithromycin-based triple therapy with amoxicillin and metronidazole, and is associated with an overall response rate of 75%. The prevalence is more wider in most variable in Chlamydophila psitta, Seborrhea burgdorferi, or Campylobacter jejuni. I will speak specifically for hepatitis C virus. This is the first prospective studies evaluating the a pure antiviral treatment, anti-HCV with direct acting antivirals for hepatitis C, so interferon-free antiviral treatment in indolent lymphomas, counting marginal zone lymphoma as the most frequent subtypes. So we treated prospectively 40 patients. All patients were eradicated, so there was sustained virologic response in 100% of cases. The overall response rate was not different in marginal zone versus non-marginal zone cases. However, in marginal zone lymphomas, overall response rate was 48% with 26% of CR. And these are the response rates in splenic, nodal, and MALT. As you can see, the most responsive subtypes were MALT lymphomas with a response in extranodal localization in more than 70% of cases. What about localized treatment in extranodal marginal zone lymphomas? The ESG 22 demonstrated a high failure from treatment failure, freedom from treatment failure, about 88% and 10 years, with a median dose of 40 grays. Today, the dose recommended is 24 gray with involved site radiotherapy, and radiotherapy in marginal zone lymphoma has an excellent outcome in localized disease. For instance, gastric radiotherapy in after anti-Helicobacter failure has a very high response rate. Involved site radiotherapy, 24 gray, is the mainstay of management also in non-gastric extranodal marginal zone lymphoma at various sites. However, in the last years, the low-dose radiotherapy, boom radiotherapy 2+2, was increasingly adopted in selected cases because it is associated with reduced toxicity, substantial sustained efficacy, about 70% at 5 years, as demonstrated in the fourth trial. In the last year was published this very interesting prospective studies from Andy Anderson, US, that tested 4-gray boom boom radiotherapy with restaging after 3-4 months and response adapted design. There were enrolled 24 cases. If at the first evaluation with endoscopy plus imaging at 3 or 4 months, if ACR was reached, the patient were observed. If PR was achieved, it was mandatory restaging after 6 to 9 months, and if not CR, the remaining dose of 20 grays were administered. In patient with progressive disease at the first evaluation, patients were treated with 20 gray. So you can see that only 5 patients required at the end of the day the highest dose of radiotherapy of 20 gray, and the 3-year local control rate was excellent, 96%. So this is a very interesting strategy, sparing dose of radiotherapy with very low toxicity. So probably this is a very good strategy in localized disease. What about splenectomy? In splenic marginal zone lymphoma, traditionally was a first-line treatment with good PFS and OS. However, there are pros and cons. The main cons is that this is not a not curative strategy, which is maybe associated with toxicity related to the surgery. So this is not usually adopted today. Rituximab monotherapy is considered as the standard treatment in splenic marginal zone lymphoma. However, this is based mainly on a retrospective studies by Greek colleagues. There is no prospective study evaluating rituximab monotherapy in splenic marginal zone lymphoma. This is the study from Kalpadakis et al., showing that rituximab monotherapy with or without maintenance was associated with an excellent response rate and prognosis. However, this is a retrospective study. Maintenance was delivered at physician discretion. However, this is a very used treatment upfront adopted in splenic marginal zone lymphomas. ESG-19 is an old study, however, is the first randomized study in external marginal zone lymphoma. The study tested the 3 arms, chlorambucil, rituximab chlorambucil versus rituximab monotherapy. The winner arm was rituximab chlorambucil, that was associated with a better progression-free survival, 72% at 5 years, with probably a best prognosis in marginal zone lymphoma that is more indolent with respect to non-gastric marginal zone lymphomas. Recently, we published as ESG group another study, a phase 2 study evaluating rituximab maintenance after an induction of rituximab chlorambucil. The treatment was well tolerated. There was also an increase in CR rate after maintenance, and 5-year progression-free survival was 87%. Compared to the previous study, LG19, this is a historical comparison. The 5-year PFS was 87%, so more important, more effective than 72% that was found in the previous study. However, the best treatment with higher CR rate and progression-free survival is bendamustine rituximab, as shown by the phase 2 Gaetano study evaluating BR as first-line treatment in this subtype of external marginal zone lymphoma. The design was a response adapted with staging after cycle 3. If CR, patient received only 4 cycles. If PR, patient received 6 BR cycles. So you can see CR 98% and 7-year PFS was higher than 90% of case at 7 years. So very effective treatment. Also, a Italian US retrospective study showed a great efficacy of this combination. In this case, the 5-year PFS was 80.5%, and there was an impact of rituximab maintenance with 5-year PFS more than 94% of cases. However, rituximab maintenance was obviously associated with infections. Concerning splenic marginal zone lymphoma, BR was tested prospectively in the BRISMA study, ESG 36. Sorry. This is the design was also response adapted, and the overall response rate was very high as well. CR rate, 73% of CR rate, with, however, a substantial toxicity, especially in hematological toxicity, with about 43% of grade 3 or higher neutropenia, but with limited rate of infection, the grade 3 or more infection, about 5%. 3-year PFS was 90% and 3-year OS 96%. So this regimen is recommended for young patient, fit patient, probably with splenic marginal zone lymphoma with lymph node systemic symptoms and a more aggressive disease with respect to patient need to be treated with only rituximab monotherapy. So we are going toward a chemo-free frontline treatment in marginal zone lymphoma. This cartoon summarizes some of the novel agents that have been tested also in marginal zone lymphomas. I'll speak about some of these agents. However, BTK inhibitors are the best, the frequently used agents, ibrutinib and zanubrutinib. PI3K inhibitor have been extensively tested, however, now has been retired probably for toxicity. There are also a great interest in these specific antibodies, also in loncastuximab, tesirin, and obviously also the combination of lenalidomides with rituximab. So this is a list, a table listing some of new agents that has been tested in marginal zone lymphoma. Usually, this agent has been tested in conjunction with follicular lymphoma, and the number of patients was lower than follicular lymphoma patient. As I see, I said before, all PI3K inhibitors have been retired from the market and from the development in marginal zone lymphoma. So let's speak about ibrutinib, the first BTK inhibitor that has been tested in a prospective study in marginal zone lymphoma. 63 patients were tested. Patients had to be pre-treated with at least an anti-CD20 containing regimen. The median number of prior lines was 2, and the overall response rate at first evaluation was 48%. The dose is standard dose for mantle cell lymphoma, 560 milligrams once daily. Median time to response is 4.5 months, and at the median follow-up of 19 months, the median PFS was 14.2 months. However, in the update of this trial, these are the final results. Overall response rate increased to 58%, and median PFS increased to 15.7 months. Median duration of response in responding patient was 27.6 months. It has been found that patient pretreated with only rituximab had a better outcome after ibrutinib, while patient pretreated with immunochemotherapy had a worst outcome. These are the results of our real-world study in Italy, presented at ASH 2023, showing a median PFS of 20.5 months. However, the median follow-up was only about 13 months. So this data will be updated and published. This is the Malibu trial, that is the fourth phase 2 study evaluating a chemo-free treatment in marginal zone lymphoma, ibrutinib plus rituximab, a doses of rituximab, and up to 2 years of ibrutinib. This study enrolled 130 cases of extranodal and a small subgroup of splenic and nodal marginal zone lymphomas. The data has been released only from splenic and nodal marginal zone group. As you can see, response rates were high from both the subgroup, 97% in splenic and 93% in nodal marginal zone lymphoma. However, the progression-free survival was significantly lower in nodal marginal zone lymphoma, while in splenic marginal zone lymphoma at 2 years was very good, 86%. The data are pending from the largest group of extranodal marginal zone lymphoma. The other BTK inhibitor that has been tested in marginal zone lymphoma is acalabrutinib, a small study of 43 patients with an overall response rate of 52%, but a very long duration of response in responding patient and a median PFS of 27 months. The BTK inhibitor that has been studied more extensively is the zanubrutinib in the Magnolia study. So you can see that the first evaluation, the overall response rate was higher than ibrutinib and acalabrutinib, 68%, with also 25% of CR. And the duration of response was longer. The last update of the study was 73% at 24 months, so the median was not reached, and PFS was 83%, 82.5% at 12 months, and the last update, 71% at 24 months. All MSL subtypes responded. So this agent has been approved by FDA and from EMA, and is widely used in patients with relapsed or refractory marginal zone lymphoma. All the subtypes, as I mentioned before, responded with the best response rate in nodal marginal zone lymphoma, 76%. And this is the PFS rate that is very high, about 70% in all the subgroup, and the duration of response was higher in nodal and extranodal marginal zone lymphoma, about 73% and 24 months. Overall survival was very high, with the lower overall survival 80% in nodal marginal zone lymphoma. Comparing toxicity in marginal zone lymphoma for the three BTK inhibitors, probably zanubrutinib and acalabrutinib, as in CLL, has lower toxicity profile with treatment-emergent adverse events being lower, especially in hemorrhage, but typically in atrial fibrillation. However, the infection rate was consistent also in zanubrutinib study, Magnolia study, 16.2% of cases there were infections, while in ibrutinib was even higher. Zanubrutinib now is testing in a phase 3 fashion in the Mahogany study that tested zanubrutinib plus rituximab versus lenalidomide plus rituximab, and that accrual has been completed for the MSZL cohort. Finally, this is the first randomized prospective study in splenic marginal zone lymphoma comparing rituximab monotherapy. So this study will test prospectively will validate rituximab monotherapy in splenic marginal zone lymphoma, and the experimental arm is zanubrutinib plus rituximab for 1 year in case of complete response, or 2 years if PR will be detected at 12 months. So the maximum duration of this scheme is 24 months. This study is currently running in Europe. In case of BTK covalent BTK inhibitors, pirtobrutinib, that is a non-covalent BTK inhibitor, has been tested. Pirtobrutinib, as in CLL, has been demonstrated to be effective also in BTK-resistant cases, in covalent BTK-resistant cases. It has a different mechanism of actions that probably stabilize BTK in a close inactive conformation, blocking access to upstream kinase and phosphorylation of Y551 site. However, these are the data in about 36 patients. As you can see, the overall response rate is about 50% and 46% in patient previously treated with covalent BTK inhibitors. So this is a very small study. However, pirtobrutinib demonstrated response in a high-risk subgroup of patients. Briefly, median PFS was about 9 months in covalent BTK inhibitor-treated patients. And duration of response, median duration of response was about 7.4%. And however, pirtobrutinib, very good safety profile with very low grade 3 or higher adverse events related to the drug. Few words about rituximab plus lenalidomide that has been tested in the augment study in a very small subgroup of patients. However, it has been approved by FDA. And also the MAGNIFY study tested maintenance with R2. However, R2 has no great role, in my opinion, in marginal zone lymphoma. If there are no other option may be used, however, the data are not very supportive of this combination. An emerging class of new agents that seem to have a very great efficacy in marginal zone lymphoma is the bispecific antibodies, CD20 CD3 bispecific antibody that link both CD20 and CD3, activating effector T cell to release enzyme interference, leading to lymphoma cell deaths. These are the three bispecific antibody under development, especially in marginal zone lymphoma. The data for odronextamab has been released at the last ASH meeting and are very effective. This is the N2 study evaluating a step-up dose scheme, and the treatment will be until progression. Briefly, these are the response rates presented. So all responder achieved the CR, and the CR rate was impressive, about 77% in all the subgroups. So it's very impressive responses, and responses were observed across all high-risk subgroups independently from prior BTK inhibitor exposure, autologous stem cell transplant exposure, or double refractoriness, or POD24. This is the duration of response, median not reached for the all cases or the three subgroups. So responses were durable, however, the follow-up was still short. And this is the progression-free survival and overall survival that are also very good. Neither median PFS nor median overall response, overall survival were reached. What about the toxicity? The step-up dose consented to reduce the CRS cytokine release syndrome with only grade 1 and 2 CRS, no ICANS where events were reported. Probably the main toxicity of this class group of agent are the infections. Any grade of infection were 69%, grade 3 or higher 24%. However, there were no grade 5 infection. Most frequent infection were COVID-19. The trial has been started during the pandemic, CMV, upper respiratory infection, and herpes zoster. However, anti-VZV prophylaxis was mandated. Generally, the toxicity profile was manageable and consistent with previous experience published in follicular lymphoma. Currently, this trial, Olympia 5, is going on, and this is a randomization between odronextamab plus lenalidomide and R2 for a time-limited fashion in 12 cycles. Another trial involving bispecific is mosunetuzumab, is the MARSUN trial from Lisa and Phil, comparing mosu plus lenalidomide with investigator choice R2 or R-bendamustine or R-CHOP. Finally, CAR T cells in ZUMA-5, together with follicular lymphoma, also marginal zone lymphoma patients were enrolled. In 31 patients with marginal zone lymphoma were treated with axi-cel, with a median 3 prior lines. Grade 3 CRS was 9%. In marginal zone lymphoma, there were significant rate of grade 3 ICANS, 36%, no grade 5, however. These are the updated results presented at the last ASH. Overall response rate was extremely high, and especially CR rate 65%. These are the updated progression-free survival curves. As you can see, median was not been reached, and at 5 years of follow-up, PFS was 53.9%. These are the duration of response not reached at 5 years, and tightness treatment not reached at 5 years. So very effective treatment in marginal zone lymphoma. However, this is not approved because the patient group with marginal zone lymphoma was smaller. Overall survival was extremely good, 71% at 5 years. The toxicity in this last update, no events, significant events were shown, only 3 new events not related to axi-cel, mainly second cancers. Another agent that has been tested in marginal zone lymphoma is loncastuximab tesirine, so an immune conjugate. Only 23 patients in the Miami study from Lossos et al. Presented at last ASH. Results were very promising, with 91% of overall response rate, CR 70%, and the toxicity is consistent with previous experience in the LBCL. Finally, BTK degraders. There is a fantastic new class of agents that may form a complex between BTK and H2 and E3 ligase, leading to ubiquitination and degradation, targeted degradation of BTK. There are many compounds in initial phase of development. This agent has been presented at last ASH, BGB 16673, that has been demonstrated to lead to a substantial reduction in BTK protein levels in peripheral blood and tumor tissue. So a prospective study, Cadence 101, is underway. These are the preliminary data in follicular and marginal zone lymphoma, very few patients. However, the patient was extremely pretreated, and the toxicity was extremely manageable. Only 3 patients has a treatment-emergent adverse event that led to treatment discontinuation. There was no adverse event leading to death. So the phase 2 recommended dose has been reached at 500 milligrams, and this has the preliminary response in marginal zone lymphomas. Overall response rate was 64%. So considering that all these patients were extensively pretreated, the majority with covalent BTK inhibitors, there are very good data. I think this is my last slide. So to conclude, marginal zone lymphoma consists of 3 different lymphomas with distinct biological features, with peculiarities in differential diagnosis and staging. Frequent instances, there is no conventional approach. There is an high activity on immunochemotherapy. BTK inhibitors probably in the future will be moved in first line. However, there is a need of predictive tool. Marginal zone IPI may be a good response to this need. The BTKi, especially zanubrutinib, are now the standard in relapsed or refractory cases, beginning from second line. However, there is no standard treatment in covalent BTK inhibitor-resistant disease, and the class of bispecific antibodies, CAR T-cell. I have to mention that there was a press release that Lysocell has been reached the primary endpoint also in marginal zone lymphoma, so probably there will be a future also for CAR T-cell in marginal zone lymphoma. Finally, the non-covalent BTK inhibitor and BTK degraders are emerging treatment options in this disease. Thank you very much for attention. I think this is my last slide, and
Thank you so much.
Thank you very much.
Thank you so much, Professor, for a fantastic lecture. We covered the entire margin zone lymphoma from top to bottom, and that was a 360-degree view of the entire journey of margin zone lymphoma. What is new? I think today we are updated so well today. Hats off to you. Fantastic lecture, sir.
Thank you. Thank you very much.
And I now request all our discussants to please put the raise hand sign so that we can start our question session with Dr. Malli. Yes, ma'am. Dr. Roshni Pandey, ma'am, your question, please.
Hello, sir. Thank you for that wonderful talk. A great learning experience. The first question is how to approach cytopenias post BR.
Thank you very much.
Yeah.
Yes, thank you very much for the question. Obviously, G-CSF may be widely used in neutropenia after BR because it's been associated with a high grade of neutropenia. So there is a primary prophylaxis, but you use typically primary prophylaxis or secondary prophylaxis with G-CSF in BR-treated patient. In some cases, also reduction of dose from 90 milligrams to 70 milligrams per meter square may be adopted, especially in elderly patients. And also, I suggest to use a response-adapted number of cycles. So, patient with a complete response after 3 or 4 cycles may be treated only with 4 cycles and not with the 6 cycles, because probably the last cycles are the more toxic, especially for neutropenias, or in some cases also thrombocytopenia is a problem in this, especially in splenic marginal zone lymphoma patient and elderly patients. So I suggest to reduce dose of bendamustine in elderly patients and to use a response-adaptive strategy with an interim evaluation with CT scan or US ultrasonography in some cases.
When the patient is diagnosed, do we vaccinate at the first sitting before starting the BR?
Sorry,
will the immunization work? Immunization.
Yes, it's a very interesting question. I completely agree with you. Before start BR, I suggest to complete vaccination, immunization with COVID vaccine, influenza in cases of if there is the seasonal influenza vaccine. Also, for instance, for pneumococcus vaccine and Shingrix for varicella zoster vaccine. I suggest to immunize patient before starting BR because we know that response to vaccines will be very low after bendamustine and rituximab. I completely agree with your observation.
And what is the role of IVIG in frequent infections?
Yes, also this is a very interesting observation because especially in cases with continuous treatment, for instance, in clinical trials with bispecific antibody, it is suggested and I think mandated to use IVIG supplementation because with bispecific antibodies, the main toxicity is infection, and typically immunoglobulins IgG go down very frequently. In other treatments, for instance, BTK inhibitor, this is not so frequent. So I suggest to test periodically IgG and to supplement immunoglobulins in cases of frequent infections at very low level of IgG. However, in a CAR T cell, obviously, but also in bispecific antibodies or other immunotherapy, it will be very useful to use IVIG supplementation.
The second question is how to diagnose transformation in non-nodal marginal zone lymphoma, and what are the predictive factors for transformation?
Yes, also this is a very interesting question. There are many studies that studied histological transformation. In splenic marginal zone lymphoma, typically, it's a very not infrequent event. In cases when histological transformation is suspected, the mainstay is to perform a PET scan and to or do a splenectomy in cases of nodular uptake in the spleen, or in other external marginal zone lymphoma, a guided biopsy, core biopsy guided by PET scan. Obviously, patients with POD24 are at higher risk of progressive transformation. So we need to monitor closely this patient because of very high risk of transformation, especially after first-line BR or immunochemotherapy. So typically the mainstay of the diagnosis is PET scan and then targeted biopsy.
Is genomic profiling in terms of NGS a work in progress, or is it a part of current clinical practice?
Yes, now it is not still a clinical practice study. However, probably in the next years, a very simple test of NGS with a targeted panel of few genes may allow also to refine diagnosis and also prognosis, because it has been demonstrated that some mutations such as TP53 or other mutations are associated with a worse outcome, especially with chemoresistance. So probably the introduction of targeted agents, I mean BTK inhibitors in first line, will be moved before also on the basis of some mutations. So I think there is a very high opportunity to develop these techniques, especially the disease, especially in the peripheral blood. There is a leukemization, so only peripheral blood testing will be a peripheral blood sample will be sufficient, and also other techniques are in development, such as liquid biopsy. So probably in the future, also blood marrow test will be not always required. However, I think that the research is ongoing, and the future probably there will be a selected treatment for each mutation. Probably this is a dream, but not, I think, not so long time to to reach it.
Thank you so much, sir.
Thank you, ma'am. Dr. Tejaswini Gudibande, your question, please.
Yeah, in the elderly new onset autoimmune hemolytic anemia, do you think there is value in checking everyone for splenic marginal zone lymphoma? Everyone, do we have to check, or when they are refractory to first line?
Sorry,
Autoimmune hemolytic anemia, elderly new onset.
sorry, can you repeat? Because can you repeat? Can you repeat? I don't.
So, elderly autoimmune hemolytic anemia presenting with splenomegaly. Do we need to
Yes.
consider diagnosis of splenic marginal zone lymphoma in every case of elderly patients who are presenting with autoimmune hemolytic anemia and splenomegaly?
Yes, it's a very interesting question. The grade of suspect may be high because the autoimmune hemolytic anemia is a frequent feature of presentation of splenic marginal zone lymphoma. So I think in case of splenomegaly and autoimmune anemia, you may check for instance, immunophenotype in peripheral blood, and if there is a small population of B cell, B cells, clonal B cells, you may check bone marrow biopsy to eventually detect splenic marginal zone lymphoma. I agree.
Thank you. Any other question, Dr. Tejaswini?
Thank you, sir. Thank you.
Thank you. Dr. Satish Kumar, your question, please.
Thanks, Amit. Thank you, Dr. Michael, for that excellent presentation. So I have a patient, 60-year-old with generalized lymphadenopathy. Lymph node biopsy revealed that it was the cells were positive for CD20 and BCL2, immunonegative for CD5, CD10, CD23, cyclin D1, BCL6, MUM1, and TDT. MIB1 labeling index was less than 10%. So the pathologist gave the impression as low-grade B cell NHL, not further classifiable. Mantle cell lymphoma, follicular lymphoma, and SLL have been ruled out by immunohistochemistry. So can we take it as a nodal margin zone lymphoma?
Yes, I don't know. CD10 was positive or negative?
Negative. CD10,
Negative.
CD23,
Yes.
negative.
Yes, probably the most likely diagnosis is nodal marginal zone lymphoma or disseminated marginal zone lymphoma, because follicular lymphoma typically is BCL2 positive and CD10 negative. So it's correct to diagnose as nodal marginal zone lymphomas. And if there are treatment criteria are the same for follicular lymphoma, so GELF criteria, a treatment with standard immunochemotherapy, typically BR, should be administered. I think are good. It's a correct option you suggest.
Right, sir. Do you suggest maintenance rituximab after 6 cycles of BR?
It's a great question because there are also, for instance, in Italy, regulatory rules that we can do rituximab maintenance in splenic marginal zone lymphoma. There are no prospective trials. I showed you a retrospective analysis suggesting a potential improvement. I suggest if patient has not demonstrated toxicity or infectious toxicity during induction, and the disease, if the disease was a high tumor burden or high risk, a sort of maintenance may be useful, provided that this be possible for your health system. So I think that would be a good option. Maybe attention required to the infectious aspects, because obviously marginal zone lymphomas are high risk of infection, and rituximab maintenance increase the risk of infection. So if patient has been vaccinated before and has no demonstrated infection during induction, may be useful to use rituximab maintenance in cases of with high risk of disease.
All right. One last question. In splenic marginal zone lymphoma, who are symptomatic, treated with rituximab monotherapy followed by rituximab maintenance for 2 years, if they relapse early, like POD 24, what will your choice of management be?
Yes, it's a great question, because this a new situation, because now we have zanubrutinib approved in second line. So in first line, in case of relapse after rituximab monotherapy, I suggest I now use BTK inhibitors, because the response rate are very high. The treatment is non-chemotherapeutic, so the toxicity profile is very good, and I think that the chemo-free approach may be the best generally. However, there is a case-by-case selection. However, especially considering that age is typically high in marginal zone lymphoma, a chemo-free approach may be the one more interesting and suggested in general now.
You showed some evidence for bendamustine rituximab in SMZL. Can we use BR? Do you use BR outside clinical trials in SMZL first line or relapsed cases?
In first line or in relapsed?
Yeah, I wanted to ask whether first line do you use, or in relapsed cases you use
Yes,
BR SMZL?
Yes, it's a good question. As I talked before, there is a prospective trial, so the data are very solid, and I think that this is a very effective regimen. However, it has some toxicity. I use BR as induction in a patient with high-risk disease, such, for instance, large splenomegaly with many lymph nodes involved, and for instance, leukemization with high number of white blood cells with lymphocytes in peripheral blood, and provided that patient has typically in younger patient and younger fit patient. I do not use BR after 18 years old or very elderly patient with comorbidities. In these cases, I use single agent rituximab, but in young fit patient, may be a very effective treatment, providing a very long treatment-free interval. So I can suggest in a young fit patient with high-risk disease BR. In the second line relapsed refractory disease, it depends from previous treatments. I usually suggest targeted treatment if available, and if there is no previous treatment in these cases. However, BR, it remains an effective treatment also in relapsed refractory disease. So if there is no better option, may be used with usual careful attention.
Thank you so much. Thank you.
Thank you.
Thank you, Dr. Satish. Dr. Dheeraj, your question, please. Dr. Dheeraj?
Sir, am I audible, sir?
Yes, you're audible. Please go ahead.
Yeah. So thank you, sir. First of all, it's a very nice presentation. So my question is, in general, any lymphoma, let it be marginal zone or any lymphoma which is who are presenting with autoimmune hemolytic anemia or any other autoimmune disease per se, and if they are candidates for autologous stem cell transplant and they are still autoimmune hemolytic anemia positive, Coombs positive, can we use GCSF or can we use GCSF as such in patients with active autoimmune hemolytic anemia? My doubt is whether there is any predilection for development of antibodies to anti-GCSF, or can we use the GCSF in patients with active autoimmune hemolytic anemia?
Yes, I try to to answer and don't very well, completely the question. However, I think after autologous stem cell transplant with autoimmune hemolytic anemia, yes, I can use GCSF support if there are autoantibodies against CSF, a very rare situation. However, normal cases, I see no problem to use GCSF in this situation. Obviously, in case of autoimmune hemolytic anemia, erythropoietin stimulating agents are indicated in these cases without restrictions, and obviously steroids or rituximab in case by case. For instance, TPO mimetics in case of resistance are useful in TPO mimetics in thrombocytopenia, yes. However, frequently there are all these autoimmune manifestation in relapsed cases.
So in your practice, any patient with chemo with neutropenia, do you tend to use any autoimmune disease? Not only hemolytic anemia, any active autoimmune disease, active rheumatoid arthritis on treatment, or any autoimmune disease. If there is a neutropenia during chemotherapy, or when there is a need for GCSF, so generally you tend to use or you tend to avoid.
Sorry, I have a problem with the audio, so I didn't understand very well your question.
Sir, am I audible? Hello.
Yeah, you are audible. Please repeat your question, Dr. Dheeraj.
Yes, sir. In any patients with active autoimmune disease, let it be rheumatoid arthritis or any autoimmune disease for that matter, and if the patient is having neutropenia or any condition which is necessitating a GCSF in an active autoimmune condition, so do you tend to use in your practice GCSF or you tend to avoid GCSF in an active autoimmune disease case?
So, Dr. Mali, the question is all about the use of GCSF in the case of autoimmune conditions. Whether do you use active autoimmune conditions like rheumatoid arthritis or lupus or SLE, whether it is autoimmune neutropenia, is it advisable to use GCSF and is it safe?
Yes, if I don't usually manage a patient with autoimmune disease outside lymphomas. However, in cases of infection and autoimmune neutropenia with autoantibodies like neutrophils, in case of infection and neutropenia demonstrated, yes, we use GCSF during the infection to reduce the risk of the infection. Yes, we use it not as prophylaxis if in case of chronic neutropenia related to autoneutrophic antibodies, but in case of infections. Yes.
Any other question, Dr. Dheeraj? Okay, he's muted. So, any other question, Dr. Dheeraj? Yeah.
Can I ask a question?
Yes, Dr. Narendra, sir. Please go ahead.
Yeah, I'm Narendra from Delhi. I was wondering that in this current era of BTKI, as a newer BTKI, do we have a role of lenalidomide or like drugs? Because here in India, we are lacking newer BTKI. We are not having zanubrutinib or non-covalently binding BTKI. And lenalidomide is easily available and it's not very costly, very cheap. So what do you feel, sir?
Okay, this is a very good question because we don't have many data about lenalidomide because we have the augment study where only 63 patients were treated and the response were not different from rituximab monotherapy. We tried to test lenalidomide in also in association with clarithromycin in a study I don't mention in ESG, the CLIO study. The regimen demonstrated an activity. However, when we stopped the treatment, the disease tend to relapse. I think that lenalidomide with rituximab R2, R square, may be an active regimen in marginal zone lymphoma. Now, the currently ongoing clinical trials, randomized clinical trials, use R2 as a control arm. So an efficacy has been probably demonstrated. However, I think that the duration of response will not be very long in case if used in a fixed manner. However, R2 with the classic scheme with rituximab with 12 months R2 may be an effective treatment, and now it's very cheap because there is the biosimilar and the cost is very low, differently from BTK inhibitor, maybe an option. I used this regimen in patient relapsed from BTK inhibitors, and I saw many response. However, we need probably to have more data about prospective clinical trials. The Magnify study has not been published, has been only released at ASH meeting. Probably it would be an effective regimen. However, there are other agents that are probably more effective in marginal zone lymphoma. Probably R2 is more effective in follicular lymphoma than marginal zone lymphoma. However, we have not sufficient data to answer to this question. However, if there are no other possibility, other chances, treatment may be an effective regimen and practical regimen to deliver.
Thank you. Thank you, Dr. Narendra Agarwal, sir. Dr. Jovita Daniel, your question, please.
Yes. Dr. Michel, it was an excellent exposition, and I thank the organizing team to have had me as a discussant here. I just want to ask you, in a resource constrained position, like in our country, we have a lot of financial issues. So would you position the molecular test to be done upfront or when the patient relapses? Because what we see here is that upfront, even if we have the molecular test done, and if we do have the targets, we don't have the data to use it upfront. We only have data for BR. So what is the right way to position the test?
Yes, it's a very interesting observation. I agree with you, because if in a case of a resource limited health system, I think that only the test, the highly cost test with a practical rebound, a practical use should be used. I think in first line, there are still no data to stratify treatment according to molecular data. So probably you will select the treatment according to stage, disease, and presentation, and treatment criteria, tumor burden. And in case of relapse, probably if you have a chance to give a target treatment, a molecular testing may be useful for guiding treatment, especially TP53 mutation may be useful to addressing patient to, for instance, BTK and not to chemo, or chemo that probably are not very effective in relapsed disease with TP53 mutation. So it is not formally demonstrated. However, the data are consistent with worse prognosis and chemoresistance, also in marginal zone lymphomas for T53 mutation. There are many data from, for instance, UK and also from European data, ESG, that suggest that T53 mutation are associated with worse prognosis with standard treatments with chemotherapeutics agents.
As an extension of the same question, is there a possibility of change of the molecular genetics, like how we see in a solid tumor in lung? It's an evolving tumor that the receptors keep changing, so we may have a loss and a gain. So is there any possibility like that with a marginal zone in the molecular testing?
If I correctly understood the question, there are probably, for instance, loss of antigens such as CD20 or CD19. I think before, for instance, treating patient with anti-CD20, CD3 bispecific antibody, CD20 testing should be mandated. And of course, in case of treatment with anti-CD19 agents such as loncastuximab or CAR-T-cell anti-CD19 treatment. If I correctly understood the question, because it
Yes,
is
I
correct,
think
it's your answer.
yes. What I was trying to say is, if there's a PIK3 mutation, could there be a loss of a PIK3 mutation? In a case
T53
like that.
mutation. Yes, generally, in increasing the number of relapse, the TP53 mutation is acquired, such as in CLL. So it's very rare that after relapse a clone T53 negative emerges if the disease was T53 mutated. So it's very infrequent event. Typically, at later relapse, T53 mutation is acquired. So probably the more aggressive disease is associated with T53 mutation after relapse. We saw many cases that acquire T53 after relapse from after immunochemotherapy or other treatments.
Okay. Thank you, Dr. Michelle. There's one question. If we have paraprotein-related conditions in patients, so in those cases, is it right for us to keep a screening program for lymphomas, like marginal zone lymphomas, so that we pick them up quickly?
Yes, frequently, I don't mention details, but marginal zone lymphoma, especially splenic marginal zone lymphoma, are frequently associated with paraprotein, typically IgM. Frequently, there is a differential diagnosis requirement with Waldenstrom or lymphoplasmacytic lymphoma with splenomegaly. So, if in cases of detection of paraproteins, especially IgM, we suggest ultrasound of the abdomen to highlight eventual splenomegaly. Yes, because it is a thing to be to be evaluated, because frequently it's a rare disease. However, in some cases there is a associated marginal zone lymphomas and not a Waldenstrom. Yes.
Thank you so much. Thank you so
Thank
much.
you to you.
Thank you, Dr. Jovita. Dr. Neha Kamble, your question.
Good evening, everybody, and thank you to the organizing team for the kind invitation to be a discussant and lovely presentation, as everybody has been agreeing on this. My question is a little different, maybe on the biology of the NHLs. So just as we are seeing clonal hematopoiesis in myeloid malignancies, lymphoid chip is one of the entity that has come into picture in the last 2-3 years. So I wanted to know how has your experience or your team's experience been with the association of L chips and the progression of disease in NHLs or maybe SMZLs, to be specific, because we see a lot of data on CLLs. We are seeing a lot of data for L chips in follicular lymphomas, but not much on MZLs or SMZLs. So has there been anything from your team on that?
It's a great question, very specific question. Yes, L-chip is a very new experience, very new evaluation. Our group is evaluating myeloid chips in the myeloid clonal hematopoiesis, for instance, in mantle cell lymphomas. We have just recently published in Blood Advances an experience in mantle cell lymphoma with myeloid chips. We are also trying to study our chips in prospective studies, probably not in marginal zone lymphoma because we have not we do not have prospective Italian studies. I don't know in Malibu studies the data are the samples are centralized in Switzerland in the lab for of Davide Rossi, and probably they are trying to do very refined tests. I don't know if there is L-chips. One of the component of our team, that is Riccardo Moya, is studying specifically these tests in Novara, that is near Milan, and is a he's an expert. He has a project that won a grant from our group, and I know it is studying L chips. If you want, I can give his contact. If you can write the email, and I'll give his email, because it's a very specific field. I'm not an expert in L chips, but I know that is a field that is currently evaluated.
Oh, great. You've been very kind to help me out with that. And I thank you so much. And I'd surely love to get in touch with you regarding that.
Thank you very much.
Thank you. Thank you.
Okay.
Thank you, Dr. Neha. So there are some questions from the audience. There are 4 or 5 questions. One question has come from Dr. Sinwin regarding the role of doxycycline in the treatment of eyelid or lacrimal gland extranodal margins or lymphoma. Your comments on that?
Sorry, can you repeat? I don't understand the first part.
Use role of doxycycline for the treatment of eyelid extranodal margins or lymphoma.
Yes, this is a very debated issue. I do not talk a lot about this issue because there is a group in Milan that is San Raffaele and Rasferri that studied this field extensively and published a very convincing set of data. So probably, however, this data has not been confirmed from other countries. Typical US colleagues did not find the association with chlamydia, Chlamydophila psittaci, and they do not found efficacy from doxycycline. I think that if there is a country or a geographic region with high prevalence of infection of Chlamydophila, this agent may be searched, may be checked in the pathological specimen with PCR, and if the disease is not progressing or is symptomatic or has mild symptoms, a short trial for doxycycline may be instituted, and then rechecked at short time with, for instance, a magnetic resonance. If there is no response, the standard treatment with, for instance, radiotherapy should be instituted. In some cases, we observed some responses. So I think that this is a management that should be tailored in cases of very high prevalence or high prevalence, no prevalence of Chlamydophila psittaci, but not in all over the world has been demonstrated. So if there are no data in your region, I think I do not recommend this case. However, in case of asymptomatic disease, in case when a watch and wait approach is planned, a treatment tentative may be instituted.
Thank you, sir. There is one case which has been summarized by Dr. Subhang Goswami. He has a case of 60 years female, comorbid in the form of type 2 diabetes mellitus on oral hypoglycemic agents and gets a extranodal margins of lymphoma which is CD5 negative, CD10 negative, B cell NHL labeled as extranodal margins of lymphoma of the right breast. Lugano stage 4, MALT IPI of 2 to 3, high risk, performance stage is 1, received 3 cycles of BR, and after 3 cycles of BR, went into PR, partial remission, and then again given 3 more cycles, so total 6 cycles of BR, went into CR as the end of treatment. So now the question is whether to offer rituximab therapy maintenance here, number 1. Number 2, whether to go for CNS prophylaxis in this case, considering that there is a high LDH, 61 years, female patient with breast involvement as well as with adrenal gland involvement.
Yes, for the first question, in that cases, yes, the patient converted from PR to CR. So this is a later complete response conversion. If there is possible and the patient not showed any infectious toxicity during BR, I think that rituximab maintenance may be used and may be effective to prevent relapse, because this is certainly an high-risk disease. The second question, can you repeat? Because another case.
The CNS prophylaxis of the same case. Yeah, because
yes,
you have the high LDH, breast involvement, adrenal gland involvement, whether to go for CNS prophylaxis upfront?
In cases of marginal zone lymphomas, I think there is no experience and no mandation for CNS prophylaxis. However, I should check if there is not a transformation. If there is a transformation, I suggest CNS prophylaxis. So I will probably check with biopsy, with PET-CT and targeted core biopsy to exclude the transformation. If there is no transformation, I suggest only monitoring. Probably a diagnostic lumbar puncture may be performed. However, I do not suggest CNS prophylaxis if there is marginal zone lymphoma without CNS demonstration, and if there is no transformation. If there is a signs of transforming disease, yes, I suggest CNS prophylaxis, because yes, the adrenal involvement is an high risk in the LBCL. It's very rare case, however, it should be evaluated with attention carefully, yes.
Thank you, sir. Another question which has just come up from Dr. Raghvendra Rajesh Warkar regarding the serum PCR for opportunistic microbes, and if it is positive, any role in the management in the patients with marginal zone lymphoma if they are come as positive in serum PCR, these opportunistic microbes like chlamydia, Burgdorferi, skin infections, skin microbes. So any role in the management of marginal zone lymphoma, or straight away we can go for chemotherapy only or chemoimmunotherapy and not giving any antibiotic therapy for such patients?
So can you repeat the question? I didn't understand very well.
If microbes comes as positive in serum samples with the help of PCR, any role of adding antibiotics in such patients who are positive for microbes in case of marginal zone lymphoma?
So patient with positive from which
serum samples positive for opportunistic microbes.
Opportunistic. Yes.
Opportunistic microorganisms.
Okay.
Like Burgdorferi. So in such patients, do we need to offer antibiotics plus immunochemotherapy, or only antibiotic or only immunochemotherapy?
Yes, I think in these cases the risk of infection, progression of infection is very high if you use immunochemotherapy. I would exclude immunochemotherapy. Yes, probably immunotherapy plus antibodies, depending of disease risk and so on. However, in case of demonstration of presence of opportunistic infections, immunochemotherapy, marginal zone lymphoma should be carefully evaluated. And if it is possible to omit them, I suggest to omit them, yes. To omit immunochemotherapy. Only immunotherapy plus antibody prophylaxis.
Perfect. Thank you, sir. Another question from Dr. Mehak Trehan. What is the best second-line therapy according to you in marginal zone lymphoma? Is it BTK inhibitor? Is it PI3 kinase inhibitor? Is it bispecific antibodies? Or is it any land-based regimens? Out of this, for which is the best, according to you, second best?
Second line, yes. Typically, we use in first line outside clinical trial rituximab monotherapy in splenic marginal zone lymphomas and immunochemotherapy in extranodal or disseminated or nodal marginal zone lymphoma. Second line, usually for me the standard treatment is BTK inhibitors because we have the strongest data. In third line, after BTK inhibitor, my favorite option is bispecific antibodies, but are now currently only in clinical trial. However, we use odronextamab in clinical trials, and we have outstanding responses in very high-risk patients. So this is an investigational situation. So now in the clinical practice, in second line, for me, the best treatment is BTK inhibitors, covalent BTK inhibitors.
Great, sir. Thank you so much. Another question from Dr. Santosh Kumar. Is there really efficacy of giving vaccines to the patients of marginal zone lymphoma, as there is already altered B-cell homeostasis in such patients? So how efficacious will be to give vaccine upfront before starting the therapy in such patients?
So vaccine therapy for
before starting any treatment for marginal zone lymphoma, vaccinating the patient, is it really efficacious? Because we are dealing with a situation with an altered B-cell homeostasis.
Yes, I suggest in case, yes, I suggest to vaccinate with upfront all patients with marginal zone lymphomas because they are very high risk of infection, and if they need to start immunochemotherapy, to have been vaccinated is certainly a protective factor. So I think I suggest a widely vaccination approach in these cases. Yes.
Thank you, sir. And Dr. Victor, do you have any other question?
Sir, one question, that's simple, sir. Sir, is there any role of intralesional rituximab in the ocular adnexal EMJDL, sir?
Sorry, international rituximab?
Interlesional, ocular adnexal.
Ocular marginal zone lymphoma, is there any role of intralesional rituximab?
Yes, it's a very great question. It's a very specific case. Yes, we have some patient that has been treated with intralesional ocular rituximab, and this has been effective. So in very selected cases where there is a chemo-resistant disease in this specific site, especially if there is a involvement of the retina or the humor aqueo, yes, intralesional rituximab may be effective. However, there is a need of very expert ophthalmologists to deliver this treatment. So only specialized centers in Milan. We have San Raffaele where there are specialized ophthalmologists in this situation. However, there are data of efficacy of this specific delivery of rituximab.
Thank you, sir.
Thank you.
It was a nice discussion, sir.
Thank you.
Thank you, Dr. Victor. So, sir, I've finished all the questions from the audience. Any discussion want to ask any other question? Well, So there are no more raising signs and there are no more questions from the audience. So thank you so much for that fantastic and lovely talk. Wonderful discussion. Tremendous learning from you. It was the 360-degree view of the entire marginal zone lymphoma. And I think from tomorrow onwards, the care for this for our patients with marginal zone lymphoma will be bright and up to date from you, sir. Thank you so much for enlightening the knowledge of marginal zone lymphoma. It was too useful for all of us. Thank you so much.
Thank you to you for your kind introduction and to your attention and for all the audience for the questions. Very exciting to answer to you and to interact with you. Thank you very much to your group.
Thanks a lot, sir. And I again thank all the discussants and the audience to participate in this webinar. Meet you tomorrow, 11:30 a.m. Thanks a lot. Thank you so much, sir, once again. Bye.
Bye.
Thank you.